Good evening to everyone and welcome to today's wonderful evening with Dr. Murali Bharadwaz. I hope that our journey in preventive medicine, totally there are 4,000 points. We finished 1/20th of our journey. So totally 20 marks come in preventive medicine. That means till now, whatever that you have studied, you are sure to get 1 mark out of 20. Yeah. So that's a whole idea. Very happy to see the online students. And thanks to Dr. Teja for attending the evening session. And let's make the great beginning. Now, can you check whether the voice is loud and clear? So, survival rate. So, what is survival rate? Basically, survival is after a given period of time, how many people who are diagnosed are still alive? So, whenever we say 5-year survival, that means the total number of patients alive after 5 years out of the total number of patients who have been diagnosed and treated into 100 gives you the survival rate is what you need to basically remember. In the survival rate, what is the whole purpose? In order to prognosticate, we use the survival rate, generally in the cancer conditions. Now, if you are using a particular chemotherapy, radiotherapy, or a new modality of treatment of malignancy, survival rate can also be used as a yardstick for the assessment of the standard of therapy, is what you need to understand. So, when you are calculating survival period, the starting point is from the day of the diagnosis or from the day of the start of the treatment, you calculate the survival period is what you need to understand. Now, if you are comparing the death rate of two populations, for example, Japanese versus Indians, crude death rate is not the correct yardstick. Because in India, if somebody dies at 70, you call, okay, old man died. But in Japan, they say, oh, how young he died. Because in Japan, people easily live up to 100. So that is the reason, whenever the age compositions of two different populations are different, then we cannot use the crude death rate as a comparative tool for comparing the death rates between two populations, is what you need to remember. So what we need to do whenever there is a different composition of the age, then we need to do what is called age adjustment. Yeah. So whenever just check is it clear? Age compositions are different. We need to do standardization. It can be a direct standardization or indirect standardization. So how do we do the standardization? So we take one standard population. What is the meaning of a standard population? A population in which you know clearly in each age group and I mean, how is the age stratification of that population? How is the sex stratification of that population? Once you know that, then that is basically called the standard population, is what you have to emphatically remember. Now, two standard populations that we use worldwide is European standard population is one of the standard population that we often use. Now, which population can we call standard population? Obviously, the one in whose age and sex composition that we know is called standard population. There are some available standard population, or you can create a standard population, or you can use the national population data. Anything can be used as a standard population is what you have to remember. So commonly we use the standard population in occupational studies, where we compare the mortality in an industry and the general population is what you need to remember. All right. Now, what are the types of standardized death rates? As we said, direct standardization, indirect standardization. So in the direct standardization method, what do we do? Indirect standardization method, what do we do? You have to be very clear for the tomorrow's NEETPG exam. We take the age-specific rate of the population. Age-specific mortality rates. Age-specific mortality rates. So you have a population of interest. You have taken the age-specific mortality rates are known. You applying that, you have created a standard population. Then you get what is called expected deaths. So total expected deaths divided by the total standard population will give you what is called standardized death rate. So basically you know age-specific mortality rate. That means, let us say 30% of the people die between the age group of 60 to 70. Let us say between the age of 60 to 70, you have 100 people. So what is the expected deaths? 30% of that. That means 30. Right? Then the expected death rate between 50 to 60 is 20%. Let us say in this given population, you have 20% is the expected death rate and 100 people are there. So that means 20 expected deaths are there between that age group. So like that, you got the total expected deaths divided by the total standard population will give you what is called standardized death rate. So this is how direct standardization is being done. So what you are doing in direct standardization, you are taking the population of interest, right? Population of interest. You are applying age-specific mortality rates, which are known in that population. And by that, you are getting total expected deaths divided by the total standard population will give you standardized death rate. Then, what is the primary premise on which the direct standardization is calculated? You can ask them to close the door. Eh? Can you please close the door? Close the door. Yeah. So first is you need to have the age-specific death rate of that population, which you wanted to standardize. Then you need to have the population every specific group, age group. Suppose there are no pediatric patient at all in that population, then that cannot be standardized using direct standardization. So these are the two important things which are the prerequisites for you to do the direct standardization is what you need to remember. So the standardized mortality rate is what you use a measure in indirect standardization, right? So now the question, how do you calculate standardized mortality ratio? So there is a standard population and you have one study group. The standard population is having certain known death rates. You are trying to apply those death rates to the study population. For example, between the age of 60 to 70, 20% is the mortality. You will check in that is in the standard population. Then what you're trying to do is in the study population, you are trying to check how many people are there between 60 to 70. 60 to 70. And then you will try to apply the mortality rate of the standard population to the study population. And then you will calculate what is called standardized mortality ratio, which is called indirect standardization. That's what you need to remember. So in this, what is the primary assumption that you are doing? You are assuming that the study group also follows a similar kind of death rate pattern as that of the standard population is what you need to remember. So when do we use indirect standardization? Whenever there is no feasibility for direct standardization. So in the direct standardization, what was the first important criteria required in direct standardization? We are assuming in the direct standardization that we already know the death rates in each age group, right? Suppose we don't know that, then we will take one standard population similar to our study population, and their death rates you bring and apply here. That is indirect standardization. If you already know the death rates, then you will use the direct standardization, right? So the feasibility factors which are not there in direct standardization method, you can use them. Then you will use the indirect standardization method is what you need to basically remember. Now, what are the examples of indirect standardization? If you calculate standardized mortality ratio, how do you get that? Typically, you have observed the actual deaths happening between 60 to 70. Actually, only 20 people died. But 20 out of 20 people died out of 100 people in 60 to 70 age group. That is what observed death, real death. But what you have done actually, you have the study group, you have the standard group, and based on the standard group, right? In the standard group, 30% is the death rate between 60 to 70. So in this population, you are expecting 30 by 100 to die. That is expected deaths. But actual observed is only 20. So this 20 by 30 will give you what is called standardized mortality ratio is what you need to remember. Similarly, life table analysis, survival analysis, regression analysis, multivariate analysis, they're all the examples of indirect standardization, is what you need to basically remember. All right. So once more summarize, doctor. Direct standardization uses age-specific death rates. If you know already the deaths in each age group and the amount of population in each age group in the given study population, then only you can use the direct standardization. Right? Whereas whenever those things are not available, then you use indirect standardization, where you take a standard population, use the death rates there, apply it to the study population and calculate expected deaths. And already there are some observed deaths formed. Observed by expected deaths will give you standardized mortality ratio. Based on the SMR, you can calculate the mortality. So that's what you do in indirect standardization, is what you need to remember. So in this whole story, 2 points, if you remember, it's more than enough. Examiner is very happy, man. What is that? They are very happy. What are the 2 prerequisites for direct standardization? Examiner want it. Understand? Now, incidence. What is the meaning of incidence? Number of new cases occurring in the defined population in a specified period of time is called incidence. Tomorrow, will you be able to come at 12 o'clock afternoon? Or how are you occupied? You can come? Because tomorrow evening, my son's engagement is there. So that's the reason I will be, still I want to take class. I don't want to break it, right? So Bhagya, you also invite students at afternoon 12 o'clock tomorrow. Okay? Only tomorrow. But day after tomorrow, grant tests are there. For grant tests, you should pull as many number of people to come to the center and take the test. Okay? So that's the plan. So, tomorrow afternoon 12 o'clock, we will have a continuation of PSM class. Now, incidence. What is incidence? Incidence is number of new cases occurring in a defined population during a specified period. Not the old cases, only new cases. Just like the water is freshly falling in, is new cases. Already the water present plus new water that came is prevalence. And out of that, some of the cases, old cases are gone because of the death or because of the recovery. The number of old cases come down. Right? So new plus old is prevalence. And prevalence can come down sometimes because the old cases either died or recovered. So the number of old cases are decreased. So that also can decrease the prevalence. So just because prevalence decreased means, don't think that our treatment is very effective. Maybe that lot of people died or naturally recovered, not because of your treatment, right? So that's what we need to remember. So incidence is the new cases divided by total population at risk. That's what you need to remember. Total population at risk is what need to be remembered. Right, doctor? So incidence is the total population, the denominator, and the new cases of the disease in a year is in the numerator, is what you need to remember. So incidence is a rate. Incidence is a rate expressed per thousand is what you need to remember. Per thousand is what you need to remember. Now, what is attack rate? Incidence if you are calculating in a very short period of time, like for example, COVID attack, it's a very short period of time if it happened, or flu attack. So whenever there is an epidemic going on, sometimes there is a sudden increase, right? That time you need to calculate new cases happening in a small interval of time. That is called attack rate, is what you have to basically remember. Then what is meant by secondary attack rate is a very important question. Secondary attack rate. So you should know that the number of exposed persons developing the disease who are exposed to the primary case within the range of one incubation period after exposure to the primary case will give you secondary attack rate, is what you need to remember. So secondary attack rate is number of new cases in one incubation period divided by number of susceptibles. So one important point you need to remember when calculating secondary attack rate is, for example, there are 4 children. One is 8-year-old, unvaccinated. Second is 6-year, unvaccinated. But third is vaccinated, 4-year-old, right? And another is 2-year-old vaccinated. So if these 2 vaccinated people are not susceptibles, and first this 8-year-old boy got, what do you call him as? Primary case. So how many susceptibles are there other than primary case? No, these 2 are vaccinated, so they are not susceptible. Only this guy is susceptible. So only one primary case is there. And that one guy got the symptoms. So number of new cases is 1, susceptible is 1. So 100% became secondary attack rate. That's what you need to basically remember. So we did not include this primary case neither in the numerator nor denominator, because he is a primary case. So you are calculating secondary attack rate. So don't include primary case neither in numerator nor in denominator. That is what you have to basically remember. So if you look at the incidence is the best measure of the disease frequency in the etiological studies, is what you need to remember. Incidence you can calculate by cohort study, because cohort study is typically you are following the cohort over a period of time and you are identifying who are the new cases which are becoming affected. So that is the reason a cohort study is the one which you need to do in order to calculate the incidence, is what you need to remember. Now, what is prevalence? Prevalence is the total number of old plus new cases over a period of time, is what you need to remember. Now, there are 2 types of prevalence. One is called point prevalence. Period prevalence are the 2 types of prevalence that you need to remember. Suppose you have seen for the old and new cases only during a single point of time, 10th February, only single point, that is point prevalence. You have done it over a period of 6 months, that become period prevalence. That's what you should remember. So prevalence is total new plus old cases of the disease in a year divided by total population into 100. So what is prevalence? Prevalence is a proportion. Prevalence is not a ratio. One of the favorite questions. Why? Because numerator is a part of the denominator and it is expressed as a percentage. That is, multiplier is 100. So that is the reason prevalence is a proportion, but not ratio, is what you have to basically remember. So how do you determine the prevalence? Prevalence is basically done with cross-sectional study. In the cross-sectional study, what is cross-sectional study? What is longitudinal study? You have taken a population and then you checked for new and old cases one time. That is, in 1 week you have checked the entire population, how many new old cases are there. But you have followed the population over a period of time. That is longitudinal study. Regularly, if you are following, that is called longitudinal study, is what you have to remember. So, if the population is stable and the incidence and duration is not changing, then prevalence is equal to incidence into mean duration of the disease, is what you need to remember. So it is the incidence and mortality and recovery. Just before we have seen mortality or recovery will decide the prevalence, which has got new cases plus old cases. New cases plus old cases is what you need to remember. Now, prevalence has two factors. One is incidence and duration. Incidence talks about the causal factors. Duration talks about prognosis. Because duration depends on what? Mortality or recovery. Mortality is a negative prognostic factor. Recovery is a positive prognostic factor. And overall, duration is dependent on these two. So duration reflects prognosis and incidence reflects causal factor, is what you need to remember. Now, if you take the point source epidemics, how do you describe them? There is a sharp rise, sharp fall, clustering of the cases within narrow interval of time, and all cases develop within one incubation period of time. That signifies the point source epidemic, as what we have discussed earlier. Some of the examples of point source epidemic: food poisoning, measles, chicken pox, cholera, Bhopal gas tragedy. They're all the classical examples of point source epidemics. Food poisoning. Suddenly, pizza is infected and entire hostel boys are eating that pizza. Entire hostel, north block or south block, got infected. Right? That is point source epidemic. Common source epidemic. It is because of the continuous or repeated exposure. So is basically common source. Even in common source also, there's a sharp rise, but the fall doesn't happen easily. It happens with secondary waves. COVID is an example of common source or continuous or a repeated exposure epidemic, is what you have to basically remember. So a contaminated well in a village, or a nationally distributed brand of the vaccine, or a prostitute in an area which is causing a gonorrhea outbreak, Legionnaires' disease outbreak in Philadelphia, they're all basically what? Common source epidemics. Propagated epidemic. Even COVID falls. COVID also is a kind of propagated epidemic, because person to person transmission is there and it continues to propagate until the herd immunity is adequate. Susceptibles are depleted, or susceptibles are no longer exposed to infected people. But propagated epidemic, there is a gradual rise and gradual fall. Gradual rise and gradual fall. That's what you need to remember. So what is the factor that decides the speed of propagation of this propagated epidemic? It is the herd immunity, secondary attack rate, chance of contacting. They all decide the speed of the spread of a propagated epidemic is what you have to emphatically remember. Now, doctor, there are some examples of propagated epidemics like HIV, tuberculosis. They're all examples of propagated, gradual rise, gradual fall with interrupted by secondary waves. That is propagated epidemic. Endemic is constant presence. जब तक हम जिएंगे तब तक हमारे साथ हमारा बैक्टीरिया वायरस भी जिएगा. जियो और जीने दो. Endemic, right? So endemic is basically every disease you expect to continue to stay, and the cases happen at an expected frequency, then you call endemic, is what you need to remember. Hyperendemic means constantly it is there, but there is a high incidence, number of cases are higher than the usual endemic levels, and it is present in all age groups equally. Children, adults, pregnant, non-pregnant, everybody similarly. That is hyperendemic. Then what is holoendemic? Holoendemic is also a high level of infection, but it begins early part of the life, and the most affected are the pediatric population. That is what you need to remember about the holoendemic, is what I want to underscore to all of you. Pandemic, all of you know very well. It is there across the world. Then you should not forget point source epidemic. All cases develop within one incubation period is what you should remember. Then what is sporadic? Sporadic is 2 to 3 cases in Tamil Nadu, 4 to 5 cases in Meghalaya. So they are all scattered around. That is sporadic. So cases are widely spread, both geographically and also in time. They show no connection. Why the Meghalaya is developing dengue fever may not have relation with few cases reported in Andaman. And there is no recognizable source of infection that lead to development of sporadicity is what you have to understand. So, doctor, typically we have prospective cohort study. It starts with exposure and it is forward looking. Retrospective cohort study also. You have taken a population and checked in their past whether they are exposed. Entire population you checked based on the records. Right? That is retrospective. A mixed is both. And case control is already there are cases. So you are looking backward. Case control. Cross-sectional study. Even in cross-section, you are observing for new plus old cases. So already exposure happened, outcome happened. And cross-sectional is neither forward-looking nor backward-looking. If a cross-section is followed over a period of time, then that becomes a longitudinal study. Right? So 3 to 4 points about each of them we need to basically master. Prospective cohort study. The outcome has not yet occurred. In prospective, outcome has not yet occurred. Only exposure occurred. And we try to look forward. between exposed and non-exposed group, how the disease is going to happen. That is called prospective cohort study. Retrospective, both exposure as well as outcome have occurred. We go back into time to know how many are exposed and not exposed. So that is what we do in retrospective cohort. You can do combined. That is also possible. Then in case control, both the exposure and outcome are over. And typically you are going backward to know about their history. Then there is something called nested case control study. It is a hybrid design, right? Nested case control is like online classes are good, or face-to-face classes good, or listening videos is good, or studying books is good. Anything is good based upon what works out for you, right? So, what is the main problem in case control? Bias. Because already cases have, let us say, diabetes, right? And you are asking these diabetic people, let us say, drinking beer and getting diabetes. Drinking beer and getting diabetes, what is the relation you want to study? So what you are asking diabetic cases, sir, 2014 did you drink beer? A beer drinker forgets what he drank in the morning only. How will he remember what he drank, how many times he drank, with whom he drank, whether he drank beer or coconut water? What will he remember in 2014 or 10 years ago? So that is the reason what will happen in case control trials. Recall bias will occur. Then suppose if you want to do cohort, what will you do for the same situation? You will take the guys who don't have diabetes, you make them to drink beer. Regularly you will supply beer. You will open a wine shop and follow them over a period of 10 years, and after that you will check how many got diabetes. In the process, some of the people died in road accident. Somebody committed suicide. Somebody prepared for PG entrance and left the city. So attrition is the problem. Very costly. Regularly you have to pour beer into their mouth. How many beer bottles you need to buy? So cohort has its own problems. Case control has its own recall bias problem. So you combine the best of these two worlds and create what is called nested case control. So what you do is you will take cohort study. You will take a cohort, study population, right? Then you will so only the exposure has occurred when the study develops in a population. When the study begins, and when the disease develops, then two groups, cases and controls, are formed, and their exposure status is compared. You understand? So typically cohort means what should ideally should happen in cohort. Cohort means in cohort study, they have not yet become cases and their exposure has not yet happened. But in nested case control, cohort is taken such that exposure status is already ascertained, and you followed them and then checked how many developed disease in or not, just like cohort. But since exposure is already ascertained, it is similar to case control. But since you followed them forward prospectively, it is like cohort. So it is combining both the things. That's the reason it is called nested case control study. Tomorrow examiner is going to give you this kind of image-based questions and ask you to identify whether you call this as a case control or a cohort or a nested case control, everything. So if you take one cohort which you prospectively follow, whose exposure already happened, then it is not like a regular cohort. Regular cohort, exposure nor disease has not yet happened. But here already exposure is ascertained and they are continuing to have exposure. Then you will check how many developed disease and how many did not over a period of time. So you are combining both case control and cohort, you get the nested case control is what you need to remember. Then what is case series? Both exposure as well as outcome has occurred when the study has begun. In case series, first we take outcome into consideration and then go back in time taking exposure into consideration. Right? Then why don't you call that as case control? In case control also, there are already cases. So you are taking outcome into consideration and you are going back and analyzing their exposure status. But in case control, you have cases and controls. But here, no comparison with controls. Only cases only, you have taken cases. And then you are checking in them retrospectively how many exposed and not exposed. Then that become what? Case series study. Whereas case control study, in the cases you are looking for how many got exposed, and controls you are looking at how many got exposed. Right? And in cases you are taking how many not exposed, controls you are taking how many not exposed, and then you are calculating the AD by BC, odds ratio. That is case control. Understand? So, whereas in case series, controls are not considered, only cases are considered. That becomes case series study. That's what you need to emphatically remember. Now, what is prevalence survey? Prevalence survey is also called cross-sectional study. So, in cross-sectional study already, the outcome has happened, exposure as well as outcome has happened at the time of study. But one single instance we take. We don't take multiple instances, unlike in longitudinal study, whenever you are doing cross-sectional study. So if you look at the prospective cohort study, right, it is also called concurrent or a current cohort study. Outcome has not yet occurred, only exposure occurred, and we look for the development of the same disease in both exposed and non-exposed groups. That is called current cohort study. So some of the examples of prospective cohort study, otherwise current cohort study, is Framingham Heart Study, Doll and Hill's prospective study on smoking and lung cancer. That is Doll's and Hill's prospective cohort study. In retrospective, it is also called historical cohort study or a non-concurrent cohort study, which we already discussed. Some of the examples of retrospective cohort study. What is the effect of fetal monitoring on neonatal deaths? What is the PBC exposure and angiosarcoma of the liver? They're all the examples of classical examples of retrospective cohort study is what you need to remember. right now. Now comes very, very interesting, very, very important part of the story. 1 minute. Sometimes suddenly when I hit this thing, it goes back. Now, give an example of combined prospective and also retrospective cohort study. Court Brown and Doll study on the radiation therapy, effect of radiation therapy, is an example of combined prospective retrospective cohort study, is what you need to remember. So, how do you calculate uh, in a cohort study? How do you calculate the strength of association? So, you have a risk factor, you have a disease. Just a disease, risk is associated with disease is not enough. How strongly is it associated is what you need to know, which is called strength of association. For that, we use relative risk, attributable risk, population attributable risk. These are the three words that we need to basically know. So, what is relative risk? Incidence among exposed divided by incidence among non-exposed will give you relative risk. So, 100 students took a NEETPG coaching. How many became toppers? 100 students did not take coaching. Still, how many became toppers? Incidence among non-exposed. This ratio will give you relative risk. That is, if you take coaching, what is the risk of getting seat in NEETPG? Is getting seat in NEETPG is risk? Kind of risk. Because life is screwed up as a postgraduate. Then what is the attributable risk? Incidence among exposed minus incidence among non-exposed divided by incidence among exposed. Understand? So, we'll give you attributable risk. You simplify this equation. Incidence among exposed by incidence among exposed, which is equal to 1 minus incidence among non-exposed divided by incidence among exposed. This is the other kind of equation. So that is the reason this is also called risk difference. Otherwise, attributable risk, right, is important. So number of people who got PG after taking coaching minus number of people who got PG without taking coaching divided by the number of people who got seat after taking coaching will give you attributable risk between the coaching and getting seat. Population attributable risk. Incidence among the total population divided by, minus incidence among non-exposed. In this total population is entire population, exposed, non-exposed, everybody, minus in non-exposed by incidence among total population. So let us say 1,000 population is there. Out of the 1,000, those who are exposed to vinyl chloride, 50 developed bladder cancer. And those who are not exposed right? 20 developed bladder cancer. So incidence among total population is 50 plus 20, 70. Out of them, minus incidence among non-exposed is 20. 70 minus 20 divided by incidence among total is 70 into 100 will give you population attributable risk is what you have to understand. So why do you want to calculate population attributable risk? It is important because if you know what is the population attributable risk for vinyl chloride, if you remove the vinyl chloride exposure, then there will be a significant reduction in the incidence of the disease among the exposed. I mean, incidence of the disease in the population. So, in order to identify what is the effect of controlling the happening of the disease in the entire population, if you remove the risk factor, you have to calculate what is the population attributable risk for that particular risk factor. Understand? Suppose you found population attributable risk after doing a study on 10,000 population in Nampally, Hyderabad, of smoking and lung cancer. You found a high population attributable risk. Then if you make people stop smoking, avoid smoking, then there is a great chance that the overall population will show fall of the lung cancers. That's the point. So if you look at the lung cancer, relative risk value is more than 1. Smoking and lung cancer. That means incidence among the people who smoked the cancer is more than the incidence among non-exposed. Then if you look at smoking and HIV, there is no relation. So incidence in exposed and non-exposed is same. Whether they smoked or no smoked, if they had a uncompromising sex, then HIV chance is equal. I mean, whether that the smoking has nothing to do with that. So if the relative risk is equal to 1, that means there is no relation between the etiological factor and the happening of the disease. Relative risk more than 1 means definitely the etiological factor has an influence on causing the disease. Whereas if the relative risk is less than 1, that means incidence, here it should be non-exposed. Everywhere it should be non-exposed. Please do correction. So, if the relative risk is less than 1, that means people who have taken vitamin A, that is incidence among the exposed, is less than the people who are not exposed to vitamin A. So if the relative risk is less than 1, it is a protective factor. Relative risk more than 1, it is an etiological factor. If it is equal to 1, then there is no relation with the risk factor. That's the point you need to appreciate. Now, 10 high-yield facts frequently asked about the cohort study. You have to be 100% sure about. Number 1, only exposure has occurred in a cohort study. Outcome has not yet occurred. Cohort study, you can calculate incidence and relative risk. Right? Incidence means new cases by entire population. So you are following a significant chunk of population while doing cohort study. That's the reason denominator, that is entire population, is there with you. That's the reason you can calculate incidence. So incidence can be calculated, relative risk can be calculated, and you are following a group of population. So you can study multiple etiological factors. Their chance of smoking, alcohol, obesity, etc. Simultaneously you can, in causing the cancer. There is no recall bias because it's a prospective study. But there are ethical problems. If people are studying that, suppose if you are studying the effect of excessive reading and suicidal tendency in a medical college, NEETPG preparing students in Padmarao Nagar, for example, what will happen? There will be a lot of news articles, controversies, and people who volunteer to participate in your study will drop down. Because when they apply in the shadi.com, no, they will say, are you preparing for PG entrance in Padmarao Nagar? If he happens to tick yes, then nobody will be ready to marry him. So that is the reason ethical problems are higher if you are following a population over a period of time. Then there's a chance of attrition, dropout. And cohort is time consuming, very expensive. And rare diseases, it is not suitable. For example, you have to do Creutzfeldt-Jakob study. Where will you get 1,000 cases of Creutzfeldt-Jakob to follow? Right? So not suitable for rare diseases. Then what are the 7 high-yield facts about case control study? Both exposure as well as outcome has occurred. Cases happened. And exposure to smoking is also over. Easy to carry out. Suppose you want to do case control trial. You will call 100 cases, 100 people who don't have the disease under study. Calling 100 people is very easy. SMS, WhatsApp, people will come. Rapid and inexpensive. And here you are retrospectively studying their past. So no risk. Whereas in cohort study, there is a risk. In cohort study, you are trying to study what? Smoking on cancer. So one group, you are encouraging them to continue smoking because you want, you are doing study. Another group, you ask to don't smoke. So, but one group you are asking them to smoke, no? That's the reason there's a risk to the people participating in a cohort study, but not case control. Already they took their risk and they already developed disease in case control. There is no loss or follow-up in case control because only 100 people. If 10 people run away, you can bring another 10 cases. And rare diseases, case control is suitable, is what you need to understand. So, doctor, cohort study. Cohort study is also called prospective study, forward-looking study, cause to effect study, exposure to outcome study, risk factor to disease study, incidence study, and follow-up study. They're all the names for the same. Cohort study is what you need to remember. Whereas case control, retrospective study, backward-looking study, effect to cause study, outcome to exposure study, disease to the risk factor study, and it is reverse of cohort. That's the reason isko bolte hai TROHOC, reverse of cohort. But what is the problem in case control? You have to get a perfect case, the one who has full disease, the one who don't have disease at all. Can you call a 42-year-old man whose fasting blood sugar is 115 as a perfect clean control? No, we don't know. Maybe his postprandial may shoot, right? Maybe his glycosylated hemoglobin may be high, though his fasting blood sugar is normal. So, perfect control ko pakadna mushkil hai, right? Then you are not studying the entire population and you are not looking for new cases. Then how can you calculate incidence? You can't. So you cannot calculate incidence. And if you don't have incidence, how can you calculate relative risk? Because what is relative risk? Incidence among exposed by incidence among non-exposed. For that, first you need to be able to calculate incidence. You can't calculate that in case control. That is the reason we use odds ratio. And case control, cases had exposure for a very remote period in the past. That's the reason recall bias is very common in case control studies is what you need to remember. So relative risk, attributable risk, population attributable risk are the ones which are used in cohort studies for calculating the strength of association is what you need to remember. Now, how do you calculate strength of association in case control study? We do odds ratio. So you have disease exposed, disease unexposed, no disease exposed, no disease unexposed. A means, what is A? A is disease exposed. A. Then not disease unexposed is D. A into D by B into C will give you odds ratio. That is how you calculate strength of association. So cases in case control are the ones who have the disease. Controls in case control are the people who are free from the disease, as all of you know very well. And the controls and cases, they should be similar in all other things. Suddenly you cannot bring ladies in Netherlands and compare them with men in Tamil Nadu. You have to bring ladies in Telangana, compare them with ladies in Tamil Nadu. That too, if these are 40 to 60, these should also be 40 to 60. Only thing is, cases should have disease, control should not have disease. Except for the absence of disease under study, cases and controls should be same in all other aspects. Age structure, gender structure, etc., etc. Now, what is the very common cause of selection bias? Hospital controls. So your boss tomorrow after you joined PG asked you to do a case control study. What will you do? Case control study means you will selectively go and pick up the cases available in OP. Controls, you are not able to get the control. The deadline to present to your boss is coming. Then you called Ellaya, ward boy, Pullamma, nurse, everybody, come on, you please are all controls. Let me check your BP, everything. So there's a chance of selection bias. Agreed? Neighborhood controls. I live in slum and my neighbor is a slum dweller. So similar socio-economic and living conditions will be available if controls are taken from the neighborhood. Siblings. If you are doing a genetic study on the effect on cancer, always sibling controls. That is, my cousins who don't have cancer are my best. They cannot be taken if you are doing a genetic study, because already genetically we both are linked to each other, right? So that's the reason what will happen. Sibling controls are unsuitable for genetic studies. Understand, doctor? So what do you use to know the strength of association in a case control study? Odds ratio, which is AD by BC, is what you have to be 100% sure about. Okay? So disease and exposure, both are there, A. Disease absent, exposure present is B. Disease present, exposure absent is C. Disease absent, exposure absent, that is D. AD by BC will give you the odds ratio. Relative risk, it is also called risk ratio. That is incidence among exposed by incidence among non-exposed. Even that also is the one which is used to know the strength of association if it is a cohort study. Now, relative risk is a more accurate estimate than the odds ratio. And how to get relative risk? Incidence among exposed by incidence among non-exposed is what you need to remember. And odds ratio is called cross product. AD by BC, hence called cross product, used in case control. It is less accurate, and formula is AD by BC. These are the 4 points you need to know about odds ratio very clearly. Now, if you look at the cross-sectional study, doctor, it is the single examination of a cross-section of population at one point of time. That is called cross-sectional study. So, if I ask you, what is the simplest observational study? बॉम्बे रेलवे स्टेशन जाओ और पूरा जनता को बोलो जरा 1 मिनट के लिए रुको, सबको फास्टिंग शुगर चेक करो. क्रॉस सेक्शनल स्टडी, राइट? Simplest form of observational epidemiological study. And using the cross sectional, you can provide prevalence, old and new cases, snapshot of population you can take, more useful for chronic diseases like diabetes. It tells about distribution, not about etiology. What is diabetes? Because of it won't tell. How many diabetics are there in the population? It will tell. And it does not establish time sequence. इडली खा के शादी करने से डायबिटीज आया, और डायबिटीज पहले से है उसको, और बाद में वो इडली खाया और शादी किया और नीट पीजी के लिए प्रिपेयर हुआ. You can't establish the time sequence in cross-sectional study. And you don't know about natural history. Longitudinal studies are best for following the natural history is what you need to basically remember. So, doctor, with this, let us call it a day. And tomorrow, 12 p.m., right? We successfully finished almost 100 points today. Tomorrow, we will try to finish at least 150 to 200 points. So slowly over a period of 40 hours, we finish 4,000 points. That's the plan. Thanks for coming.